Dan Bergen. Thanks for coming to our session, Optimizing Resources in the ICU. Our title is Assessment of the EPIC Sepsis Predictive Analytic Impact on Antibiotic Use in the ED. This work was done at Our Lady of the Lake Health in Baton Rouge, Louisiana, as part of the collaborative with the LSU School of Medicine, Baton Rouge Branch Campus. I'm currently a third-year resident with LSU Internal Medicine in Baton Rouge. The following work was funded in part by Cytovale Incorporated. Several of our co-authors have financial affiliations. I'd like to thank Dr. O'Neill, Dr. Jagno, Dr. Thomas for helping to make this work possible. Main goal today is to bring awareness to predictive modeling as it pertains to sepsis, as well as display our findings of performance characteristics, as well as the impact on antibiotic use at our facility. Little background, one of the big problems with sepsis is a lack of current tools for early and accurate diagnosis. Some emerging tools in this field, machine learning, as well as electronic health record integrated predictive models. However, there's some challenges as it relates to this field, with many of these tools being proprietary algorithms with a lack of external validation. What external validation does exist has shown poor performance characteristics. There's challenges regarding how the definition of sepsis has evolved, as well as which definitions are used in the development of these tools. And there's an implementation challenge with the balance of efficacy with the potential for harm, such as alarm fatigue. Here we focus on the EPIC sepsis predictive model as it's used in our facility. At our facility, it's an emergency department-based tool. There's no inpatient alerts that are generated. The tool is primarily driven by SIRS and blood pressure, although many other factors weigh into the tool, such as age, past medical history, diagnostics, both ordered and resulted. A score will be calculated every 15 minutes in the emergency department, and then the predictive model will trigger a best practice advisory alert once it reaches a score of 6 or greater. This is recommended by EPIC. The best practice advisory is available to both nurses and providers, which will alert them that sepsis is suspected and give a breakdown of the components that go into that. The providers can then acknowledge that, adding sepsis to the problem list, as well as prompting further order sets for diagnostics, as well as therapeutics, including antibiotics. We've previously evaluated the ESM's performance characteristics at our facility in an abstract published in 2021, which found a similar area under the curve as that reported by EPIC. However, poor positive predictive value at only 41%, meaning for every 10 alerts that are generated, only 4 will have the condition. Here we look at the same patient population, adults with 2+ SIRS criteria, in a single center retrospective analysis, where we are comparing the time of antibiotics ordered and administered with the ESM scores, particularly looking at the trigger threshold times. And the presence of sepsis was adjudicated by a physician panel using sepsis 3 definition and SOFA scores. So the ESM was reviewed in 226 patients, 48% of whom received antibiotics. Sepsis was found to be present in 21 of these patients, or 11% overall. 100% of these patients received antibiotics. Of note, the ESM did not trigger a BPA alert in 4 out of the 21 patients. We see that the median triage to trigger time was 91 minutes with a standard deviation of 445 minutes, and the median triage to order time was 102 minutes with a standard deviation of 83 minutes. Here we're demonstrating the relationship of antibiotic order to delivery. We see on the x-axis that we have time from triage to antibiotic order in minutes. On the y-axis, we have time from triage to antibiotic delivery in minutes. And we see a very tight linear correlation between the two, with a Pearson correlation coefficient of 0.82. And what this tells us is that while there are many factors that go into the difference in time between antibiotic and order and delivery, we are confident that an earlier initiation of an antibiotic order will help prompt earlier antibiotic delivery for septic patients. What we would hope to see is that the ESM would trigger and prompt providers to initiate the earlier antibiotic order. Knowing that we have this linear correlation, we could then get earlier antibiotics into these patients. However, as we see here, the relationship or the patient level overview of the time from triage to trigger, noted by the red hash marks, overlaid with the time from triage to antibiotic order, noted in the blue bars. There's really no consistent pattern. Many of the ESM triggers fall after the antibiotic orders. And of note, 4 of the 21 patients did not have an alert generated. And that's because 2 of the patients never reached an ESM threshold to trigger an alert, and 2 of them reached the threshold on hospital day 2 where no alerts are generated. Here we look at a similar representation of the statistical level view of this similar information with time from triage to trigger in minutes on the x-axis and time from triage to antibiotic order on the y-axis. And we see no tight correlation between the two, with a correlation coefficient of only 0.21. So what we conclude is that the ESM trigger is not improving the time to ordering of antibiotics for septic patients. We question whether ordering antibiotics is actually helping the score to reach threshold in some cases. And given the positive predictive value and how poor it is in this, and in conjunction with the other findings, we question the utility of the tool in its current state. We do plan to further explore this tool, possibly in alternative workflow pathways or with combination with other diagnostic tools to help improve the delivery of care for septic patients. Thank you. I'll take any questions. Yep. My understanding is it's included in each hospital's. Oh, can you repeat the question?
There is a microphone.
Yeah, why don't you come at the front? Because I'm being recorded. Do you have questions?
So my question was this ESM tool included in Epic as a base, or was it specific to each health system's Epic build?
So it's tailored to the hospitals, to each hospital's like Epic. The original tool is designed by Epic for generalized implementation, but how it's implemented is hospital specific. Yeah.
So are you in future looking into, or have you looked into like whether the right type of antibiotics was given based on this, like, you know, looking into like based on this type of model, like what antibiotics were given, like right type of antibiotics or appropriate antibiotics, like that?
Yeah, we do have information on which antibiotics were given overall, but we're primarily focused on trying to identify just was the initiation of antibiotics correlated with the actual score at all, or was it the score prompted by the ordering of antibiotics, and really trying to figure out, is this score helping to influence providers to order antibiotics earlier, or are providers already thinking about sepsis and ordering antibiotics prior to the score?
Hey, I'm Casey, one of the moderators. I'm at VCU Health. Yeah, so the Epic's proprietary sepsis score, it's a very interesting score. It's a proprietary, not a lot's been published on it. Not a lot of peer review on it. It's very, we just transitioned to Epic this last year in my hospital. We're still putting it into the ringer on kind of what our prior kind of a St. John's type of sepsis model was. If you kind of look at kind of the indices of which they utilize into it, actually giving antibiotics will up your sepsis score, which is a little interesting. There's a lot of other variety of other factors which also give you points and scores, which are up for debate. A lot of them are physiologic, a lot of them are nursing driven, or lab driven. But then there's some other bizarre factors like marital status is in there. So if you're single, you're more likely to like pop for sepsis. So I've learned a lot about it. It's very fascinating. I do think there's some utility to it. A lot of the, similar to what you found, it looks like most of the patients that do pop positive, or they do trigger positive for sepsis, based on Epic's scoring system, they may not be septic, but they're not healthy. Something is wrong with them, and I think it's prompted us to maybe utilize it, and maybe not as much as a sepsis score, but we've kind of transitioned to more to say, well, let's take a closer look at this patient, go to bedside and determine, let's have a discussion. Do we feel like this is sepsis? So we've gone now to more like a sepsis huddle, we call it, where do we feel like they're septic or not? Do we actually have to order lactates and whatnot? So as opposed to having the order set pop up and just go ahead and willy-nilly order because Epic said to, no, let's go to bedside and have a discussion of what we think is going on, and if it's appropriate, then we can move forward with sepsis. It's an interesting tool. But you had a great presentation. You guys were doing some good dives into some things.
All right, good morning, everyone. The title of my presentation is A Sense of Urgency, Boarding of Critical Care Medicine Patients in the Emergency Department. I'm Palak Rath. I'm a third-year resident physician at Cleveland Clinic Akron General in Akron, Ohio. And I do not have any disclosures to make. So, lesson objectives. We wanted to explore the impact of ED-CCM boarding during the COVID-19 pandemic in our hospital. We also wanted to add to the current body of research around this topic by presenting our findings from a single center analysis. We also wanted to foster some discussion about avenues for improvement, innovations, or discussions about new models of care. So let's go to background. ED boarding of critical care medicine patients has been a growing area of concern with increased urgency, especially during the COVID-19 pandemic, which we have been seeing for the past 2 to 3 years. ED-CCM boarding task force was convened as a collaboration of the Society of Critical Care Medicine and American College of Emergency Physicians in 2017, and then they published their review article in August 2020. Before this, we did not have any particular definition regarding what exactly ED-CCM boarding is. So this task force investigated the phenomena in depth and made several preliminary recommendations, including formally defining what ED-CCM boarding is. So according to their definition, it's either time spent in the ED after a decision to admit the patient to ICU has been made, or after 6 hours in the ED, whichever comes first. Previously, multiple investigations have been done regarding this topic, and it has been seen that it leads to worse outcomes. Specifically, it includes increased hospital mortality, hospital length of stay, increased ICU mortality, ICU length of stay, and ventilator days as well. So the task force report also highlighted that the national healthcare infrastructure was not equipped to deal with a surge or pandemic event. And we saw that during COVID-19 pandemic when there was a huge burden over the healthcare system in the United States. New models of care have selectively emerged since then, specifically the ones which have combined emergency department and the ICUs, and they're also known as resuscitation care units with dedicated ED intensivist providers. So most literature which we have focuses on large hospitals and academic centers, but we do not have a lot of literature about this situation in rural and community hospitals. And that was one of the major reasons why we decided to go ahead with our project. Study design and methodology. So we assessed the impact of ED-CCM boarding at Cleveland Clinic Akron General, which is my home hospital, and it's a 532-bed hybrid community academic center in Akron, Ohio. We did a retrospective chart review of 455 patients who were admitted to MICU service between October 1st, 2020 and January 1st, 2022, of which we found that 145 patients were positive for COVID. We also sought to determine the impact of boarding time on patient outcomes, including ICU length of stay, ventilator days, and 30-day mortality. Additional correction was also performed to adjust for illness severity using Apache 3 score. And we did this because we did have initial hypothesis that the patients who were critically ill, who were the sickest, were the first ones to be transported to MICU. We also did a subgroup analysis of COVID-19 patients who also presented with respiratory failure and not just incidentally COVID positive. Boarding time was calculated as the interval between when the ED provider placed a MICU consult and when the patient was actually transported to MICU. Linear regression analysis was used to assess associations between boarding time and ICU length of stay and ventilator days. Logistical regression analysis was used to assess association between boarding time and 30-day mortality. This analysis was controlled for Apache 3 score, and additional linear regression was applied to assess an association between boarding time and Apache 3 score. A significance level of 0.05 was applied for all the tests. So here we can see the basic demography of our patient population. So for all the patients, we had a male predominance. Average MICU length of stay was 2.1 days. Ventilator days were 5, and boarding time in minutes were 205. We also have demographic for a subgroup of COVID-19 with respiratory failure, but due to time constraint, I won't go into that. And here we can see the table about outcome variables for all comers. So we did find that there was significant association between boarding time and ICU length of stay and ventilator days for all comers after controlling for Apache 3 score. We did not find any significant association between boarding time and 30-day mortality for all comers after controlling for Apache 3. We also did not find any significant association between boarding time and ICU length of stay, ventilator days, as well as mortality for the patients in the subgroup of COVID-19 and presenting with respiratory failure. So, conclusion, no associations were observed between boarding time and 30-day mortality for all comers. There was a statistically significant association between boarding time and ICU length of stay for all comers. So for every additional minute of boarding time, ICU length of stay increased by 0.026%. And similarly, for every additional minute of boarding time, ICU ventilator days increased by 0.023%. So subgroup analysis was insufficiently powered to detect differences within the COVID and respiratory failure subgroup, so that is why probably we did not get any significant association. In our study, patient population was just in the hundreds. It was 455, and that was probably the reason why it did not lead to significant associations, as sufficient statistical power was not there. There was no statistically significant association between illness severity and boarding time as well. And this actually refutes our initial hypothesis that the patients who were sickest were the first ones to be transported to MICU. The average patient with an average boarding time of 205 minutes experienced a 5.33% increase in ICU length of stay and a 4.72% increase in ventilator days because of boarding. Now, we did have some of the patients who were boarded in the ED for more than 24 hours. So if we apply this same stats to those patients, then we can see that their ICU length of stay and ventilator days increased by 1/3, which was pretty significant. Additional covariates, such as nurse-to-patient ratios and total ICU patient census, could be assessed in future investigations, and we plan to do that. We haven't done it yet. And that was my presentation. Here are my co-authors. I would like to thank them, Dr. Jerusalem, Dr. Devakar, and Dr. Schreiber. Here are my references, and thank you, everyone. And I'm open for questions. Yes?
Thank you. What do you think your EDs? Is it like lack of intervention immediate, or what kind of cause is the, behind this increased length of stay of the ventilator days?
So I think for the patients who get boarded in the ED, there are several factors. For example, the intensivists, the nurses who are actually trained to provide care to MICU patients are up there in the MICU. The staff, including the ED physicians, the nurses, they are not trained to take care of ventilated patients, for patients on pressors for a very long time. Also, we saw that in our hospital specifically during COVID pandemic, there was shortage of staff as well, specifically the nurses. And I think the major reason why we have this significant finding is that for the patients who were there for a longer time, specifically the ones who were there for more than 24 hours, did not get the exact same care as they would have gotten up there in the MICU. I think the intervention in this which could have been done was probably providing more staff to the ED, maybe transferring some of the MICU nurses down to the ED, or probably moving them to step down or step up units where they could have gotten better care. Mm-hmm. Okay. And the other thing is that even respiratory therapists, the whole RT team in the MICU is much more trained. They are there 24/7, but in the ED, specifically in our hospital, we do have respiratory therapists over there, but again, they're short-staffed over there. They usually take care of the patients for like 3 to 4 hours, not for more than 24 hours. And I think the intensivists are better trained to take care of mechanically ventilated patients and handle ventilators. Thank you.
I definitely think it's probably, just given it's a retrospective, a lot of confounding. There's probably a lot of different things to say. I don't know, probably staffing could be one. Some expertise, experience could be coming into play as well. But I'm sure that, given that, I'm sure there's a lot of different other variables that you could roll in to kind of piece out some of the confounding that's going on. So it's a great question. Thank you. Good job.
All right. Good morning. I'm Amy. I'm an internal medicine resident from Mayo Clinic in Rochester. Very excited to be presenting our project today, gaining consensus on expert role statements for a digital twin patient model in the ICU using a Delphi method. So kind of a long and confusing title, bear with me, hopefully it makes sense here in a few minutes. But just to start, what even is a digital twin? The concept of digital twin technology has been previously used in various fields outside of medicine, such as aeronautics and ecology. The ICU digital twin is a virtual counterpart to a real ICU patient. Actionable physiologic interactions are described by the expert rulebook. The digital twin is organized by unique expert roles for each organ system, with this project focusing on the respiratory system, pathophysiology, and critically ill patients. These interactions are further described by a directed acyclic graph, or DAG. The DAG can be used to translate programmable code to run the digital twin. This is unique from previous artificial intelligence models that rely on analytical algorithms in a black box model where clinicians are not made aware of the actual data process. So our digital twin has been previously studied in our ICUs for patients in the first 24 hours of sepsis. This allowed for methods for verification and prospective validation to be established. So essentially, the digital twin is capable of integrating vast amounts of data to create a digital replica that can inform clinical decision-making in an actionable way. So this is our respiratory system example of a DAG for our digital twin. The solid arrows represent cause and effect. The solid red boxes represent actionable concepts, and the dashed red boxes represent semi-actionable concepts. The interactions from the DAG were created into several main statements. Each main statement is then further described by 6 survey questions describing the direction, intensity, timing, probability, contingencies, therapeutic implications of the respiratory physiology at play. 34 pulmonary and/or critical care experts from around the world were invited to participate in this study. Each question was then rated on a 6-point Likert scale. Questions that reached at least 80% agreement were excluded from subsequent rounds of the survey. Questions that did not gain consensus were reviewed by a steering committee where they were either modified, unchanged, or removed from the final survey statements. This is showing our diverse panel of expert survey participants. These were located in 6 different countries and 6 different United States with a diverse range of institutional practices represented. This is a flow diagram showing each round of our Delphi process. You can see the number of participants that participated in each round, as well as consensus for each round of Delphi as well. And this is an example survey question from our very first round of the survey before any edits were made, where you can see the main statement and our 6 sub-statements here. Free text comment boxes were included for each question as well as the end of each round of the survey, so participants' opinions could actually help with the modifying of the Delphi as we went. After 3 rounds of Delphi were completed, we reached 87% consensus on our 71 final statements. The most agreement was reached on statements relating to airway obstruction affecting alveolar ventilation and the effects of alveolar infiltrates on ventilation perfusion matching. Least agreement was found for the interaction between shock and hypoxemic respiratory failure, as well as ARDS, increasing dead space. Now that we have our expert statements with consensus, this will be used to now code the respiratory system for the digital twin. The updated digital twin will be validated in comparison to real ICU patients, like we previously did with the sepsis. Once the digital twin is further verified and validated, this can be used to improve ICU medical education, research, as well as support for clinical decision-making to look at outcomes of interventions without having to expose real patients. Thank you to all of our expert participants and collaborating authors. Okay, thank you so much.
Any questions?
Did you find any reason of why, for certain conditions, they could not reach an agreement? Like, is there any particular reason of why they could not reach it? Is it because of complex nature, or?
That's a great question. We got a lot of agreement. I was thinking back on this, and the one specifically, our statement for shock and hypoxemic respiratory failure, the statement was that there's a increased oxygen consumption without an increased oxygen delivery. And I looked into the literature on this too, and that seems to be a controversial concept throughout, ICU physiology. So I think just the innate nature of that statement, our steering committee felt that there was a relationship, but I can understand how more widespread it is a controversial opinion, which was actually very interesting to kind of be highlighted by our Delphi, matching the literature. And then the ARDS one, I think if you look at the DAG, It really, I don't know if you can see my mouse. It's like the top left corner, and you can see it's relating really to ventilation perfusion mismatch. And all of our statements that reached a lot of agreement were worded to be ventilation perfusion mismatch. I wonder if we had just said that rather than specifying dead space, which is more controversial because the statement was by, I actually wrote it down here. Increasing dead space by vascular injury and/or overdistension with increased PEEP. I could see where that would be more controversial than just saying ventilation perfusion mismatch. So,
For all the physicians, pulmonary critical care, or did you just have some just critical care?
we had a wide range of expertises represented. We actually had two pharmacists, critical care pharmacists involved. We had one pediatrics person, several ED crit, as well as not clinical critical care, but some basic science pulmonary physiologists represented as well. So very diverse. Infectious diseases, cardiac crit. Yeah. Thank you. Thank you for the questions. Awesome. Thank you all.
Hey everyone, my name is Nicholas Clucciello. I'm presenting our abstract for the study, Passing the Sniff Test, a secondary analysis of a sepsis transition intervention trial among patients discharged to post-acute care. I'd like to thank my co-authors, Dr. Kowalowski, Dr. Kukin, Dr. Wardy, and Dr. Taylor, and we have nothing to disclose for this study. So sepsis survivors experience multiple problems after discharge from their initial stay in the hospital. They're at a very high risk for mortality and hospital readmission. Over 1/3 of sepsis survivors are discharged to post-acute care as they are not stable enough to go home. And of these patients discharged to post-acute care, they experience higher readmission rates as well as mortality rates than those who are discharged home. So it's a very vulnerable group of patients. The purpose of our study was to compare the effects of a sepsis transition and recovery, or STAR program, versus the usual care alone on 30-day mortality and hospital readmission among sepsis survivors discharged to post-acute care. So this study was a secondary analysis of patients from the Improving Morbidity During Post-Acute Care Transitions for Sepsis, or IMPACTS, randomized clinical trial. And we specifically analyzed the patients who were discharged to post-acute care rather than all patients discharged after a sepsis. So the IMPACTS evaluated the effectiveness of STAR, which is a post-sepsis transition program using nurse navigators to deliver best practice post-sepsis care during and after hospitalization. This includes comorbidity monitoring, medication review, evaluation for new impairments and symptoms, and then goal of care assessments. So here's a schematic illustrating the STAR program, and you can see here any patient who is hospitalized for sepsis and flagged as high risk, they undergo an initial telehealth assessment via a nurse navigator. During this, they assess the patient's health literacy, mental health, functional status, and then they also make any necessary referrals or consults. And this assessment is sent to the care team. During preparation for discharge for this patient, they are given sepsis education, explain their sepsis recovery care plan, their meds are reviewed, they're referred to a pharmacist if they are on any high-risk meds, and this care plan is again sent to their providers. In the early transition period, after their discharge, within 48 hours, they undergo another review of medications, symptoms, vitals, functional status. They're provided with any other resources or support they need, and then their care is escalated if deemed necessary. This is repeated again at the 3 to 5 day and the 7 to 10 day interval. And then through 90 days, they undergo weekly review of symptoms, vitals, functional status. Again, if they need provider support, that's given, and care can always be escalated. And then they're linked to their next care setting after 90 days. So it follows them through the discharge and post-discharge period. So patients that were hospitalized with sepsis and deemed high risk for post-discharge readmission or mortality and discharged to post-acute care were randomized to receive either the STAR intervention or usual care. The primary outcome we were assessing was a composite of 30-day readmission and mortality for these patients. So this graph shows where we got our patients from. So there was 691 patients originally enrolled in the IMPACTS trial. Of these 691, 175 or 21% were discharged to post-acute care, the majority being to skilled nursing facilities, a smaller percentage to long-term acute care and inpatient rehab. And then of these 175 discharged to post-acute care, 88 received the STAR intervention and 87 received usual care. So this chart is showing our primary results. So 30.6% of patients in the usual care met the endpoint for 30-day all-cause mortality remission compared to only 20.7% of those who underwent the STAR program. So this was a negative 9.9% risk difference. For 30-day all-cause mortality, we had 8.2% of the usual care that had mortality compared to only 5.8% of the STAR program, and this was a negative 2.5% risk difference. And for 30-day all-cause readmission, this occurred in 27.1% of those receiving usual care compared to only 17.2% of those undergoing the STAR program, or a negative 9.8% risk difference. Of note, if you look at the 95% confidence intervals for the risk difference in odd ratios, it shows that the results are not statistically significant. We believe that one limitation of our study was that it had a small sample size, likely leading to low power and thus affecting the statistical significance. But regardless, the secondary analysis of the IMPACTS trial found that the STAR intervention may decrease 30-day all-cause mortality and hospital readmissions in high-risk sepsis patients discharged to a post-acute care facility. Any questions? Sure.
I was wondering if you were able to stratify the data based on the kind of sepsis, the source of the sepsis that the patients were involved in, and how were the outcomes in that? Like if the patient had a UTI, they had better outcomes and less readmission as compared to those with pneumonia.
So we did not stratify based on the source of the sepsis. I think that with already, this is already a secondary analysis where we've taken one kind of unique group and then we've further substratified that to those only discharged to post-acute care. I think that initially adding too many other factors might have kind of confused the results we were looking for, but I think that's a very good question and something that should be looked into in the future, and definitely would be interested in larger studies with more patients to see kind of how the effects go over a larger group, but that's a very good question.
Is there any COVID patients involved in the study, or?
So I don't know off the top of my head the exact sources of the sepsis. I would not be surprised if there were, but again, I don't know the sources again of the sepsis.
So the STAR program is amazing. The outcome of 30-day mortality, I guess it's very important, but I know there was a great talk this morning talking about, post-sepsis syndrome and whatnot, and, going beyond 30 days, going beyond just mortality, looking at really, yes, mortality is awful, but looking at kind of these long-term, manifestations of what sepsis can cause. I don't know if you guys had any thoughts about following up with that.
I do have a chart here that's kind of showing the different process measures that were involved. So this kind of can show all the different things that the STAR program provides for the patients, and also the issues they're treating. So you can see they're getting physical therapy, outpatient rehab, speech therapy, mental health assessments, physician office visits in an appropriate amount of time, goal care. So, it's like you were saying, post-sepsis syndrome, there's so many things that go into that. The patient's mental health, needs for physical therapy, speech therapy. And so we're really trying to cover all of that to improve their outcomes. So, yeah, no problem. All right, well, thank you, everyone.
Good morning, everyone. I am super excited to be here, and more so without a mask. I'm here to talk about a study that's titled Increasing Hospitalizations Related to Ventilator-Associated Pneumonia, Insights from the National Inpatient Sample Database. And my name is Namrita. I'm a second-year resident physician at MedStar Georgetown Washington Hospital Center at Washington, D.C. As we all know, healthcare-associated infections have been a significant burden towards patient outcomes. Especially, that's one of the most important adverse events when it comes to patient safety. And an important contributor to that is ventilator-associated pneumonia. And as we all know, it's the pneumonia that develops within 48 hours of, after 48 hours of somebody requiring mechanical ventilation. And VAP, more so in a critically ill patients, can have its impact on mortality, length of stay, among other factors. And so as part of our aim of this study, we decided to look at how the VAP trends have changed across the nation and over a period of time. So we looked at hospitalizations using the discharge data from the National Inpatient Sample, which is an interesting data set in the sense that it has discharge data of about 7 million hospitalizations annually from across the country. So our inclusion criteria for this was adults aged greater than 18 years, hospitalized between January of 2013 to December of 2019, with VAP as either the primary or secondary diagnosis using the ICD codes version 9 and 10. We did the statistical analysis using SPSS statistics, and the alpha was set at less than 0.05. So this table beautifully summarizes the results that we obtained. And as you can see, it looks at the rate of hospitalizations of VAP per 100,000 hospitalizations between 2013 to 19. And there has been a consistently increasing trend among males, females, and in total. To quantify this further, it was 128,000 hospitalizations with VAP in this time period, and a 50% increase from 2013 to 2019. Of the 128,000, 42,000 of these hospitalizations were associated with tracheostomy, ventilator dependence, or both. And the trend in terms of tracheostomy or ventilator dependence was an 80% increase over these years. Some general characteristics: the mean age was 58 years, 36% of the population were females. Some racial distribution. White population consisted of the majority with a 58%, followed by Black population and the Hispanic. Certain outcomes that we looked at: the median length of stay for these hospitalizations was 20 days. The median cost, quantified by the amount reimbursed by the insurance company, and this cost was adjusted to inflation using the 2019 Consumer Price Index, and the median was around $83,000 for each of these hospitalizations. We also looked at the all-cause in-hospital mortality, which was around 20%. However, there was no statistically significant difference in terms of median cost or in-hospital mortality over these years. An interesting data point that we did see that cost associated with VAP hospitalizations for just 2019 was an impressive $2.8 billion. And the median charge, as you could expect in patients with all-cause in-hospital mortality, was higher than those did not have significant mortality during the hospital stay. We also looked at how this varied in terms of race. The median age was lower for Black and Hispanic population as compared to the white population. The all-cause in-hospital mortality was lower for Black and Hispanic population as compared to the white population. And the median cost, however, was higher for the Hispanic population as compared to the white population. We also looked at how this varied by gender. The mean length of stay and the median cost was statistically significant and higher among males as compared to the females. However, there was no difference in all-cause in-hospital mortality. So in conclusion, despite the advances in healthcare and the patient safety protocols, there's still been an increasing trend of VAP-related hospitalizations, however, without a significant change in mortality. Could we speculate that this is because of the increase in number of tracheostomy and ventilator dependence that we've been seeing, or is it because our advances are better and now we can detect more of these VAP incidences amongst our patients? This definitely warrants further studies to look into individual factors affecting this trend. And this study also highlights the financial burden, and maybe identifying these factors can help us mitigate that and optimize the resources at hand. And of course, there's definitely some gender and racial disparities which warrants for us to look into and figure out why that is happening. The limitations of our study is that it's an observational design. You can definitely report association but not causality. And this is from a billing data, which means it could be subjected to several coding errors. We have to keep that in mind. And it does not have individual patient information, which makes it difficult for us to figure out what happened to them following the hospitalizations and what the outcome was going forward. And of course, since 2019 and now, we've been through a pandemic, and I'm interested to find out how the trend might have changed as a result of this pandemic between 2019 and now. Thank you all for your attention, and I'm happy to take any questions. Yes.
So using the billing diagnosis, you mentioned subject to coding errors, but could also be subject to intentional changes in coding practices, right? So as VAPs are penalized, I would have actually expected to see coding go down and coding it in a different way that wouldn't be penalized. So what are your thoughts on that and what you think you'd see if you looked at a more clinical definition of VAP? Do you think that would line up, or do you think there would be differences there?
As much as I'd like to think that we do not subject in like voluntary coding errors, but we do know that that is a practice. So I definitely think that would play a significant role here, given that the data is purely extracted just out of the coding ICD codes. And definitely, maybe even if it's not a study based on the nationwide approach, which could be difficult, and in an individual setting or like in multiple centers, it would be interesting to note and see how this trend would change if we were to just look at clinical definition and go forward. Unfortunately, that definitely is a significant limitation of the study, yeah.
That's a great point. That was exactly what I was thinking as well. Was over the years we have been, informed to potentially, appropriately code or not code certain things, or once again have there's different definitions of it gets a little muddy. But you're right, maybe we should go through the actual chart to see kind of what things are, what they.
And even the 48-hour mark is a very tricky line. So you never know. Maybe you see it on the chart the next day, and it happened the previous day. You never know.
It gets very tricky as well.
Yeah.
What's your hypothesis on the trends that might be coming up?
I think it would still be going up because COVID has been a notorious pathogen. And if anything, it just makes it harder for somebody to, as we've demonstrated. Yeah, even longer, yes. Yeah. Yeah.
Do everything under the sun to try to prevent a VAP, whether someone's been ventilated for 2 months.
Yeah.
Something's going to happen.
Yeah.
One more question.
Yes.
Have you looked into data comparing urban versus rural or teaching versus non-teaching institutions?
We do have some raw data about it. It's very nice that how this database is structured. You can pick out hospitalization, like different states, different hospitals, teaching versus non-teaching, and all of that. And we do have some rough data at hand. Unfortunately, we couldn't summarize that on our abstract, but that is an interesting thing we're looking forward to, putting on a manuscript, hopefully. Yeah. Thank you. Thank you all. Yeah.
Sorry about that. Hello, everyone, and thank you for participating in this session on optimizing resources in the ICU. My name is Nastaran Haqqani-Rad. I am an internal medicine resident in Cook County Hospital. I have nothing to disclose. On behalf of my colleagues at Cook County Hospital, I would like to present an analysis of data extracted from the national inpatient sample on hypertensive emergency admissions. As we know, hypertensive emergency is defined as significantly elevated blood pressures that lead to or associated with end organ damage. They have disturbed autoregulation of tissue perfusion. This pathophysiologic mechanism of disturbed autoregulation of tissue perfusion has impact and implications on treatment strategies. The optimal management of hypertensive emergency, the goal is essentially to limit and prevent further end organ damage. And we achieve that by obviously one, immediate recognition of hypertensive emergency, followed by blood pressure management, which is immediate reduction of blood pressure, using continuous infusion of short-acting, titratable antihypertensive medications while avoiding excessive reduction of blood pressure. Clinical experience has shown that significant excessive reductions of blood pressure may lead to renal, cerebral, and coronary ischemia and need to be avoided. The reason why we use continuous infusion of short-acting antihypertensive is essentially to prevent the cumulative hypotensive effect of oral long-acting medications. So as we can see, the proper management of hypertensive emergency involves careful monitoring, early recognition, initiating diagnostic and interventions in case of complications. And we can see that in every step of management of hypertensive emergencies. So as one can imagine, over the weekend, when we have suboptimal staffing, we have decreased availability of diagnostic and procedural resources, one can wonder if how this can have an impact on hypertensive emergencies admissions over the weekend. I plan to share with you an analysis of comparing outcomes of hypertensive emergencies over the weekend compared to weekdays by assessing in-hospital mortality, complications, and resource utilization. The title being, is there a weekend effect on admissions for hypertensive emergency? We queried the National Inpatient Sample Database from 2015 to 2018, and we identified patients using ICD code with primary or secondary diagnosis of hypertensive emergency. Essentially, we sought to look into how does weekend hypertensive emergency compare with weekday hypertensive emergency admission using linear univariate regression analysis. And our primary outcome was in-hospital mortality with secondary outcomes of complications and resource utilizations using charges and length of hospital stay. We identified about 750,000 patients from 2015 to 2018 admitted for hospital as hypertensive emergency, and about 1/4 of those patients were admitted over the weekend. We noted that these two groups were comparable in terms of basic demographics. Our study showed that while there was no significant difference in terms of inpatient mortality, we noted that patients admitted over the weekend had higher rate of complications, slightly higher rate of complications in terms of acute coronary syndrome, acute respiratory failure, and acute decompensated heart failure. We also noted that the mean length of stay and hospital charges were similar between the two groups. So in contrary to the existing evidence of weekend effects, our study results suggest no mortality difference between the two groups. However, it showed a slightly increased risk of acute coronary syndrome, respiratory failure, and decompensated heart failure for patients admitted over the weekend. And this calls for, again, careful monitoring and proper management, especially when it comes to a weekend admission. Thank you very much. Thank you.
You were speaking of some of the advantages of the national inpatient sample. So
Yeah, that is a great point. We didn't look into the different hospital settings, but that will be definitely, I believe that if we look into that, we might find some differences in terms of those complication rates in between those different hospital settings. Thank you.
Kind of fascinating, 25% were admitted over the weekend. And then even statistically, I was like, that is odd. I mean, maybe I must just hang out and have the holiday effect on the weekend, but, you know.
That's an ambulatory care sensitive condition, since you can't get into your primary care line weekdays.
True.
Yeah, that jumped out to me.
Is there a specific reason you chose hypertensive emergency as a diagnosis to look at?
You mean the ICD code or just? Oh, I believe it was based on a study that came out, I think 2018, the weekend effect. There was a study that noted that patients admitted over the weekend with hypertensive emergency have higher mortality rate, and we wanted to look more into that.
Do you have a suspected reason? Like, do you think that some of these, if they were admitted during the day, they went to the primary care physician and were either treated in the office or admitted there versus going to any random ER on the weekend?
Yeah, that can absolutely be a case. Though our study didn't really look at the timeline. When did they have these complications? Was it before they arrived in the hospital, or was it during their time in the hospital? We were looking into, with the weekend effect, with having less staffing and all those differences that are kind of obvious compared to a weekday. Will that have an impact? But that is a very fair point to bring up. We didn't look at these complications. What was their timeline? Was it before or prior to their presentation, or was it a complication that happened to them during their hospital stay?
I have two questions. One question is there any difference between day and night admission of hypertensive emergency? And second question being, on weekend, acute coronary syndrome and I think acute respiratory failure was very high. Is there any particular reason why those complications are high on the weekend?
So the first question was day and night. We didn't look into it. With the acute coronary syndrome, I think of all the complications, that acute coronary syndrome had the higher odds ratio compared to the rest, the two other complications that we mentioned. I didn't really look into it more in depth, but I think acute coronary syndrome, we have to be following troponin. We have to be really like going through the diagnostic route, going through the route of calling the attention of our cardiologist. I would assume that it will be in that scenarios with respiratory failure and decompensated heart failure that we have to really, those are the scenarios that really require more and more close monitoring and following up with the patient, looking at their blood pressure and optimizing essentially diagnostic and intervention. And I would assume it will be related to that. Exactly. Yeah, thank you for that. Yeah, that is a very fair question. Yeah, thank you. Thank you.